So Rich and I are going to talk about serious illness conversations today. And I'll start with, I love that slide, so isn't that a great slide? So our learning objectives are to describe advanced directives, because I feel like you need to do that to realize the full extent of having a serious conversation and how it happens over time, and definitely in the outpatient field. To describe tools to initiate these serious illness conversations, while addressing goals of care, and to develop our own phase. Rich will go over how to develop your own phase to initiate serious illness conversations. So goals of care, I've heard it mentioned throughout the day today, and especially in our session, our breakout group. Goals of care happens all the time at each visit, and it's ongoing and changes, right? So you want to have, find out what matters to the person, and have, we typically start in the health cares program with the structured format of let's look at the healthcare proxy and make sure we have that in place and get started there. So we make sure that that's done, and then we have the guides that we use for the conversations, and you'll develop them over time to have something that feels comfortable for you. And then we use the most form too towards the end of our conversations, because we're a smaller, shorter term program. But know that, of course, these goals can change all the time and should be addressed ongoing. So the healthcare proxy, we all know, is a legal document in Massachusetts. Any competent adult over the age of 18 has a right to appoint a healthcare proxy. My hope is that all providers at all ages will ask at your physical to the accuracy of your healthcare proxy, or if you'd like to assign a trusted family member or agent. So surprisingly, this trusted family member or friend is often, it could even often be a neighbor, somebody you trust to speak on your behalf if you're not able to. And then, of course, it's important to ensure accuracy. The date is a priority. The sticker that goes above our healthcare proxies, that has a date and it has an MRN and date of birth of the patient, does not make that document legal. So the date needs to be near the signatures of the witnesses. It's an error we find often. So what tools do we use? And this was a great conversation that I almost wish that we had prior to our breakout session, because this was asked, like, what do we use? What is a great tool to use? These are the ones that we use most often. The conversation project, that's that one we use typically in our program. Once you've started, obviously the conversation is ongoing. I said that. So as you're developing that relationship with that person, once you get to a comfortable point, this conversation can ask some questions that may be uncomfortable, but very relevant and important. So you can judge how things are going with this tool. It can be given to the patient. It's meant to be, the conversation is meant to be with the family and the patient together. If that doesn't happen, you can kind of adapt it to use it yourself. Baystate uses honoring choices for our healthcare proxies, and they have a whole packet of, and a whole website actually, of some great tools to use. This is the form we use for our healthcare proxies right in our consent forms in CIS. So please don't be afraid to go ahead on the website and look to see what information you can give to patients or to their families, or you yourself to kind of use to go over before you start offering these healthcare proxies. Again, we have the conversation starter kit. Illness conversation guide is a little bit, I don't use that one as much. I found that I have it here. I find that that's how that was most helpful, is it gives you great starters, great, how it is, what is your understanding of the disease process? How do you feel, what information do you need from me as a provider? And it gives you some great tools to use as well. And then 5 wishes, I think it costs $5. You can't just print them off the website. But I really like 5 wishes too. It breaks down it breaks things down a little bit more for the patient to make it a little clearer about what you're asking. What are what interventions are possible. What is dialysis? What is a breathing machine? And breaks it down a little bit. And sometimes I have in the past gone from the end forward. And then the most is that pink form that needs to be posted on a person's refrigerator for if 911 needs to come, if the ambulance needs to come, and paramedics, and understand whether or not that person wants interventions done and to be sent to the hospital. This is that form that we make sure is signed by the patient and reviewed with the healthcare agent. How often do we examine healthcare wishes? This is a nice little slide. This makes sense, decade, or maybe with older adults every 5 years, but for all adults, I would say every decade. Death of a loved one, if somebody in your family or a spouse has died, this would be a good time to readdress those issues, because now they have different experiences, right? During a divorce, certainly, and that one maybe pertains very closely to the healthcare proxy. When a new diagnosis is given, absolutely. Or a decline in health, any change in health condition or status. I feel it's a great way to, a great opportunity to have another goals of care conversation. So always when you're working with somebody, I like this slide because it shows, it's a visualization of you're coming to that conversation with your values, your belief system, your spirituality, your ethnicity, and all the experiences you've had in the healthcare system your whole life. And remember that they're coming with their own beliefs and values, their own spirituality, their own culture, their own concept of health, and their experiences. So keep in mind that you really want to look at that person, and then it's a good idea to look at yourself so that you can put that aside and focus on the person that you're working with. So Rich, would you like to continue on with how we're going to proceed now that we have these tools? And
important stuff. Okay, so how do we proceed? This is kind of the try to give a basic overview of some of the tools that I use in conversations. From our division, we tend to think of our goals conversations with patients as a procedure. We try to approach it with a method to simply provide information and understand what a patient and family may choose to do. Can we move, Sherry? So as you're probably understanding, it's a complex task, these communication discussions that we have with patients and families to try to help them understand what is happening, understand options, and then understand what are next steps. Okay.
It's not going. Hold on.
Try clicking right on the slide deck there. Sometimes WebEx pops up and it should.
Oh.
Yeah, there you go.
Sorry.
So there's skills that are required to respond to their emotional reactions, but also we want to keep in mind what we're doing. We're trying to do some shared decision making with people. There's a lot of stress involved for the patient and the family about the outcome of potential treatments. We try to preserve hope, and we also a big one is trying to avoid miscommunication. I find that has been something that I've learned over time. It's kind of an experience type of situation. It's really hard to be clear with every certain individual, just like that one slide that Sherry showed about how we all come from different places. And that not only affects our life in general, but as you can imagine, in a situation like this that is extremely emotionally charged, how that would impact that situation in very challenging ways sometimes. Okay. So a big deal is from my perspective is to establish a relationship with the patient, with the family. We want to build trust for sure. We want them to know that we are sincere. We want them to be clear on what our role is going to be. And then we also want to help them understand why we're meeting, why we may be having this conversation, and making sure that we're implying importance upon the conversation and allowing our time for that communication or for the meeting also. Okay. So we can develop our relationship, our trust in a patient through knowing a lot about them, or as much as we possibly can. A thorough chart review is so important. We want to understand their medical conditions very carefully. We also want to understand as best as we can about maybe some of the things that they've been through in the past with, different attempts at treatments or medications or things that didn't work, things that did work. So if we can bring that into the meeting and present that to them as the conversation unfolds, that may help build some of that trust I'm talking about. I find another thing that's quite important is learning something about the patient. Not only is that interesting for me personally, but it also kind of displays to them that you actually care. One of my favorite questions, especially in our population, is finding out what somebody did for a living, and then that leads us away from the situation at hand. In a sense, it gets us out of the medical piece, the health issues, and takes us to a different place where we can spend a little bit of time and get to know them a little bit better. And it not only is that it's not just talking, because you're learning something about the person, but it may be useful days or weeks down the road if something should come up that you may need to have a way to connect with them again. So again, make a connection, and that will lead you to that place if you know more about them. Okay. So these are the questions that I use very often when I'm entering a meeting with a family. I try to talk very little up front, and the way I do that is and this is a very common question that we all use when we're entering a goals conversation, is what do you understand about your health, or tell me what you know what's happening right now. It's just a great way to allow them to vent a little bit, but also it gives you a place to understand what they know and what you need to provide them to bring them up to speed on what's happening. And then like it says, I just pause, and I just even if the pause is uncomfortable, I let the time just kind of hang there a little bit, because some people don't know what you're asking at times. They'll say, oh, well, this is going on. And I continue to push them a little bit and prompt them on getting to more of the information that they may have to this point, so that I can help them get to the next steps. Okay. So when we're sharing information, of course, we want to speak in layman's terms. We want them to understand clearly what we're defining, what we're saying. One of my examples is cerebral ischemia. That's a bizarre term that we use, very clear to us. I mean, we clearly understand what that means. But if you say that to a patient and a family, they may have no idea what you're talking about. One thing I do is there'll be times where I'll say things like that, or I'll take somebody through an MRI report. And one thing I'll do as I'm going through that portion of my discussion with them, I'll tell them, I'll say, I'm going to read you the report as I see it. And then I'm going to stop, and then I'm going to explain to you line by line what each of those things mean, so that you can understand them and you understand what I'm seeing better. And again, that all these little things that you're doing like that, meeting them where they are, you're beginning that alignment with them. You can then move on to exploring their emotions. You get right into the hope and worry situation. And again, allowing that silence, giving information, allowing them time to absorb it, and then maybe give you some feedback on what you just told them. So, okay, thanks. Again, explore, understand their emotions, understand their fears, and then as we're segueing a little bit, what are they willing to go through? You know, what is important to them? If we can help them begin that bridge as to where we go next with things and what it may mean for their life and their lifestyle. Okay. So, again, review everything at the end. I try to do that as simply as possible, especially, you know, by this point, hopefully you've come up with a bit of a plan. So you want to take them through, okay, this is going on right now. This is what we've decided to do at this point. Discuss your recommendations with them so they understand things. Summarize, ask them to summarize a little bit. They don't have to give you every single detail, but if they can give you the kind of the big picture, that's helpful too. And then I always try to affirm my relationship with them, and that I have a luxury of being involved with patients as throughout their hospital stay, when many providers are changing during that stay. But I tell them, I say, you know, I'm here all the time. I give them my phone number, I give them my card, and I also tell them that when you leave the hospital, don't hesitate to give me a call. If I can help in any way, I'll try to do that. And then know when to stop talking and know when to stop the conversation, because we can tend to go on and on. I've seen providers do this. I probably have done this many times myself throughout my career, that we just sometimes don't know when to stop talking and just let them be, because typically by this point we have overwhelmed them completely, and they need a break, a little bit of a break from us. Next slide. There's one thing I wanted to touch on briefly. This is something that I find fairly intriguing, especially as I've learned more about communication. But I also began to explore linguistics a little bit. So I just wanted to go through a couple things really quickly with you on that to help you understand that there is something about how we communicate, and we probably all had problems in our life because of something we said or didn't say or whatever. We go through that. So I wanted to bring a couple things to your attention, that there's some real things about this. So in linguistics, there's a form of speech called performatives, and I'll just read the definition. They're declarative statements with which the speaker performs the action denoted by some performative verb, e.g., a promise, a declare. In doing so, the speaker does not describe the situation but changes it, and I find that piece very interesting, that changing a situation by something we say. If we go on. So these are some examples. I will call you. I apologize for my behavior. I think you are nearing the end of your life. You are unlikely to survive. Your condition is irreversible. We will continue to treat you aggressively. Those all change the situation in many ways. It changes the way somebody thinks about something we have just said. Next slide. And constantives, another form of speech. They're statements of facts that describe something, okay? So examples are many of the things that we say in the hospital. You have heart failure. You are frail. He has dementia. She has been hospitalized multiple times this year. So again, those are other pieces of information that are the meat of a sentence sometimes, that really tell people something, give them information. And again, there's a science to this. The linguistic part of this, I think, is very, very important. And the reason why I bring this up, I think this can kind of help us all communicate better by realizing that everything we say may have some implication to it. That probably sounds intuitive, but I think if we think about that a little bit more, it may help us with our communication skills and style a bit. And I think that's about it. Thanks.